Hello, now we will look at semaglutide, which is a medication belonging to the family of GLP-1 agonists. And I will deal with the specifics of this GLP-1 agonist in another video. To make a very long story short now, one can say that GLP-1 is normally produced by L cells of the small intestine after ingesting food. And the purpose of GLP-1 is to travel to the pancreas and then activate the beta islet cells' production of insulin. And as we know, insulin will tend now to remove glucose from the blood into the cells. And this is something we strive for in diabetic patients, namely to reduce the sugar level in the blood. And there are two medication groups now that we can increase GLP-1 in the body. Namely, we have GLP-1 agonists that we deal with today and DPP-4 inhibitors. We will deal with DPP-4 inhibitors in another video. So if we compare now these two groups of medications, one can say that GLP-1 agonists are more efficient in reducing glucose than the DPP-4 inhibitors are. The main advantages of GLP-1 agonists compared to the other anti-diabetic medications are the high glycemic efficacy. This means that the medication is efficient in reducing blood glucose levels. And then we also have, for example, weight loss. We also have no hypoglycemia. Hypoglycemia means that we have a lower blood sugar level than 60 milligram per deciliter. And GLP-1 agonists usually don't cause hypoglycemia, only in cases where we combine these medications together with sulfonylurea or insulin. Last but not least, we have very long-acting effects of GLP-1 agonists, where you only need to inject the medication once weekly instead of taking oral tablets 2 times daily. The main disadvantage of GLP-1 agonists is the price. It is pretty expensive at the moment, but we will hopefully decrease the price as more and more people will realize how good GLP agonists really are. And there are many types of GLP agonists. I try to remember all these names of the GLP-1 agonists with the acronym of CELL-D. I mentioned that GLP-1 agonists are very expensive, and therefore I associate expensive with selling GLP-1 agonists for a very high amount of dollars. Thereby the acronym CELL-D. D for dollars, S stands for semaglutide, E for exenatide, L for lixisenatide, L for liraglutide, and finally D for dulaglutide. So we have semaglutide, exenatide, lixisenatide, liraglutide, and dulaglutide. And all these medications now are generally given subcutaneously, meaning under the skin in 3 main areas, such as abdomen, thigh, or upper arm. And semaglutide also has an oral tablet that has been proven effective compared to the other oral tablets of the other GLP-1 agonists that are not really good as semaglutide are. So semaglutide tablets are the best. And I would say that if you choose a GLP-1 agonist, then usually you choose the subcutaneous form, since it is a very long-acting effect, meaning you only need to give it once weekly. So that's the main advantage here. The advantage of long-acting GLP-1 agonists over short ones are that they have better reduction of hemoglobin A1C and fasting glucose. So short-acting agonists are usually better against postprandial hypoglycemia, which means that it reduces glucose better after the patient eats a meal. So some patients who eat very, very much can actually get very high levels of glucose in the blood after a meal, and therefore I would say that in these cases it is preferred to give the short-acting GLP-1 agonists over the long-acting ones. Okay? We mentioned now that GLP-1 agonists will make pancreatic beta islet cells to produce insulin and thereby reduce the glucose in the blood. Some other mechanism of how GLP-1 agonists work are, for example, that they slow down the gastric emptying, which is a fancy name of saying that the food moves slower through the stomach. Slower through the stomach, and thereby it is getting reabsorbed much slower, which is good if you want to lose weight, and also good against very big spikes of glucose in the blood after a meal. Another weight loss mechanism of GLP-1 agonists are that they reduce the appetite in the brain, and thereby you eat less and thereby you lose more weight. Okay? GLP-1 agonists will also reduce the glucagon. Maybe you have heard about glucagon being the counterpart of insulin, meaning that glucagon tends to instead produce more sugar in the blood compared to insulin that tries to reduce sugar in the blood. So imagine now that we give this wonderful molecule, in my opinion, GLP-1 into the body once a week, and it makes all these effects come true, and that's it. A very big advantage of semaglutide compared to the other GLP-1 agonists is that, and also to the other anti-diabetic medication, is that it does not have to be dose adjusted. This is one more thing, that you don't need to dose adjust it in liver and kidney insufficiency. And as we have seen with other anti-diabetic medications, we usually cannot use them in patients with, for example, a GFR, so glomerular filtration rate of less than 30 milliliter per minute. And many sick patients who have diabetes mellitus usually also have kidney insufficiency, and therefore it is very hard to choose any good anti-diabetic medication for these patients. So you see, GLP-1 agonists are really good, and most of the other medications are contraindicated below a GFR value, and semaglutide is not. And of course, this semaglutide is a very new type of medication, and perhaps in the future some studies will then show that they also have to be dose adjusted, but at the moment all the research is showing that semaglutide subcutaneously once a week can be used for patients with diabetes mellitus and also kidney insufficiency and liver insufficiency and so on. Not only does the semaglutide have a very high glycemic efficacy in patients with diabetes mellitus, but it also has a very good effect on the cardiovascular system. This is one more benefit. So it reduces the risk of cardiovascular disease, like for example, myocardial infarction or stroke. These were just some examples. And before we start to give semaglutide to patients, we now need to look at the contraindications of GLP-1 agonists. So I talked about a lot of good things. Let's see in which patient can we not give semaglutide. So if we give semaglutide to these patients, it can be dangerous. So we have the contraindications now that we list. History of pancreatitis or active pancreatitis, which is the medical term of an inflammation of the pancreas. And whenever I'm saying history of something, then I'm referring to that the patient already had an inflammation of the pancreas before. It does not matter if he had it 2 years ago or 5 years ago or 10 years ago. If the patient had a history of pancreatitis, then please do not give GLP-1 agonists to these patients. Okay? The second contraindication is history or even family history of medullary thyroid cancer or multiple endocrine neoplasia type 2. Here when I'm saying a family history, then I'm referring to the relatives of the patient. And it can be the mother or the father who had one of these diseases, namely medullary thyroid cancer or multiple endocrine neoplasia type 2. Don't give this medication in these cases. Third contraindication is type 1 diabetes, which is usually seen in younger patients. Fourth contraindication is a severe kidney insufficiency with a GFR of less than 30 milliliter per minute. As I mentioned previously, some GLP-1 agonists cannot be given in patients with severe kidney insufficiency. So a GFR of less than 30 milliliter per minute. And today we're looking at semaglutide, which has a big advantage since it can be given in patients with severe liver insufficiency and kidney insufficiency. Fifth contraindication, gastroparesis, which means that the stomach is partially paralyzed. In simple terms, the food moves very slowly in these patients. And if you add a GLP-1 agonist to this type of patients with gastroparesis, then you slow down the stomach even further. And as we mentioned, that this was one of the mechanisms of how a GLP-1 agonists work. In normal patients, it is good that you slow down the stomach, since we said it slows down the absorption of glucose into the blood. But please remember now that it is not good for patients who already have a very slow stomach. So in conclusion, one can say that you have to check at least these five contraindications before you start semaglutide or any type of GLP-1 agonist. And these were, once again, let's name them once again: history of pancreatitis, history of family history of medullary thyroid cancer or multiple endocrine neoplasia type 2. Then we have type 1 diabetes or kidney insufficiency with GFR less than 30. And then we have, last but not least, gastroparesis. So now we want to start semaglutide, we have two options, as we said. We can take it with oral tablet or we can inject it subcutaneously. The subcutaneous injections are the best, but some patients do not want to inject themselves and instead rather want to just take a tablet a day and that was it. The trade name of oral semaglutide tablets is Rybelsus, and the trade name of subcutaneous injections is Ozempic. So the oral tablets are given usually once daily. We give it 30 minutes before breakfast, and the doses that we have of Rybelsus oral tablets are 3, 7 and 14 milligram, and we always start with the smallest dose, which is 3 milligram once daily, 30 minutes before breakfast. The reason why we start with the smallest dose here with 3 milligram is to reduce the initial gastrointestinal side effects. Like we have nausea, we have abdominal pain, but then please, after 4 weeks of this treatment, it is important that we increase the dose to 7 milligram once daily. 3 milligram does not really have an effective glycemic effect. Okay, this 7 milligram oral tablet once daily should be given now for 4 weeks, and then should be increased to 14 milligram if the blood glucose is still very high in the patient with 7 milligram. The 40 milligram is the maximum dose which can be given once daily, and if the patient forgets to take the medication in the morning, then it is better to skip that day. Okay, so take the medication the next day in the morning, 30 minutes before breakfast. Please always take the tablet as a whole and do not crush it or chew it or divide it or so. It is important that when you take semaglutide tablets or any type of GLP-1 agonist that you do not combine it also with another GLP-1 agonist or another DPP-4 inhibitor, since it has no additive effect and it causes just more side effects. Insulin and sulfonylurea can be taken together with GLP-1 agonists, but it is important here that you reduce the dose of insulin and sulfonylurea while you take this GLP-1 agonist. Now, let's say that we give semaglutide tablets, namely this Rybelsus, to the patient for many weeks. And then later on he decides to take the subcutaneous form instead, since he have heard that it is actually better than the oral type. In this case, we need to consider which dose of subcutaneous semaglutide we are giving here to this patient. It is actually very simple. You will see that you always start with 0.5 milligram of subcutaneous semaglutide, namely 0.5 milligram of Ozempic. And it does not matter what dose of oral tablets the patient took until now, you always start with the 0.5 milligram of Ozempic. The next question is, when can we start with the subcutaneous semaglutide? After being on oral semaglutide so many weeks, the answer is simple, that you start to inject yourself with Ozempic the next day. That is, after you have stopped Rybelsus today, you start with it the next day. And just to recap, the doses of oral and subcutaneous semaglutide, we have oral semaglutide, the Rybelsus being 3, 7 and 40 milligram. Then we have subcutaneous semaglutide, namely Ozempic, 0.25, 0.5 and 1 milligram. And for both, we always start with the lowest dose. So for Rybelsus, we start with 3 milligram for 4 weeks. And for Ozempic, we start with 0.25 milligram for 4 weeks. But as we said, the patient was already taking the therapeutic dose of 7 or 40 milligram of Rybelsus. Then we need to switch to 0.5 milligram. And you might ask yourself, how is it possible to go from, we have the highest dose of oral tablets, namely 40 milligram of Rybelsus, to switching to the middle dose of subcutaneous semaglutide, namely the 0.5 milligram of Ozempic? The answer is that it is possible to do this, but you need to measure the blood glucose and the symptoms of the medication needs to be checked the first 2 weeks. So much more often. So in order to prevent this hypoglycemia, especially in patients taking insulin or sulfonylurea. So now what happens is that the patient later on, let's say, decides to switch from subcutaneous to oral tablets again. What happens in this case? In this case, it matters what dose of subcutaneous injections the patient already had, because the oral tablets dose will depend on it. So if the patient was on Ozempic 0.5 milligram, then we have to choose the 7 milligram Rybelsus. If the patient was on 1 milligram injection, then we have to switch to the 14 milligram Rybelsus. This means that if you was on the middle dose of subcutaneous injections, then you can switch to the middle dose of oral tablets. But if you was on the highest, then highest dose of subcutaneous, then you switch to the highest dose of oral tablets. So another difference here is also that if you was on subcutaneous injections and you switch to oral tablets, you need to wait 1 week before you start the oral tablets. So from oral to subcutaneous, you wait 1 day, and from subcutaneous to oral, you wait 1 week. Another question arises when should you take semaglutide during the day? So oral tablets, Rybelsus, should be taken 30 minutes before breakfast, once daily, we said that. Subcutaneous injections, so Ozempic, should be injected any time of the day. But it has to be the same day, each week, so with or without food. We mentioned that if the patient forgets to take the oral tablet, Rybelsus, 30 minutes before the first meal, and then he realizes it many hours later, then it is recommended to skip that day and simply just take the medication the next day, in the morning, 30 minutes before breakfast. Okay? So please do not take tablets too close to each other. It has to be around 24 hours between the tablets. It does not have to be perfectly 24 hours. It can be 20 hours, 23 hours. But the main point is that you always take it in the morning, 30 minutes before the breakfast. If you forget it, just take the medication the next day. And it's not dangerous, there's no consequences, nothing will happen to you just because you missed one tablet. Indications of subcutaneous injections, namely for Ozempic, it is a little bit different here. So let's say you always inject Ozempic each Monday here. So for some reason you forget to do it on Monday and now it is already Wednesday. The question now is if you're allowed to inject Ozempic now on this day, on Wednesday, and then inject it next week on Monday again. The answer is yes, you are allowed to inject a missed dose within 5 days. The importance is that you have to have at least 48 hours between these two doses. This means that you could theoretically inject Ozempic on Saturday morning and still being able to inject it on Monday morning the next week, since it has 48 hours in between, so namely 2 days. So if you miss an oral dose of Rybelsus, then you skip that day and take it the next day. And if you miss a subcutaneous dose of Ozempic, then you inject it so that you have at least 2 days in between these two doses. And then you continue with the injections once a week on the same day as usual. The location where you have to inject Ozempic can be, for example, abdomen, it can be thigh or upper arm. And these locations have to be changed every week. So please do not inject the medication on the same spot on the abdomen each week, because that will be a reaction then. So please change it. Abdomen 1 week and then the thigh the next week and the upper arm the third week and so on. And the needle is very, very thin and it's small, and this means that you will just go beneath the skin, because this is called subcutaneous tissue and this does not hurt, especially when you get used to it. So injections usually only hurt when you reach the muscle tissue, and this is what we call intramuscular injection. But since we are not reaching the muscle with Ozempic injections, it does not really hurt. It is just scary. And this is called subcutaneous injections. And the steps of injecting Ozempic are the following. So you first start to disinfect the skin area. As we mentioned, you disinfect the abdomen or the thigh or upper arm. Then we put a needle in this pre-filled pen, and this has to be done every week. So always change this needle every week. Then you have to turn the dose selector to the smallest dose, and then you inject it into the air. And this is what we call priming of the pen. And priming only has to be done once with one pen. You don't need to inject it into the air the next time, but directly into your skin. So only do this initially when the pen is new. And then it is time to puncture the skin smoothly. So with a smooth way, and then press the button when you're in the skin, so beneath the skin, and you hold it pressed for about 6 seconds, and then you can remove the pen. So do not puncture the skin and then quickly remove the pen without pressing this button and holding it for about 6 seconds. Now, after you're done, you can simply store this pen for about 1 month in the refrigerator, or actually even in room temperature. And if it is not more than, in room temperature, if it's not more than 25 degrees. One pen usually contains about 4 doses, that is once a week for 4 weeks. And now that the patient injected Ozempic or took Rybelsus tablets, we can in some cases expect some side effects. So the side effects are usually rare, but we need to mention them here so that the patient know that it is normal to get these side effects with a certain medication, okay? And whenever a patient gets side effects, it does not mean that now we need to stop the medication. So some side effects are appearing in the beginning, for example, and then with time they just fade away. And therefore it's important to stay consistent with taking the medication and always weighing the benefits and disadvantages of the medication. What is the benefit? Benefit is that the diabetic patient will get a reduced sugar level in the blood, and thereby they decrease the risk of complications of diabetes. And as we know, these complications all can lead to death. So the benefit of the medication is a reduced risk of death. And the disadvantage of the medication is usually side effects like nausea or abdominal pain. So let's name some side effects of semaglutide. I will start with a special type of side effect that is special for semaglutide compared to the other GLP-1 agonists and to the other anti-diabetic medications. Namely, retinopathy. And now you get scared. This means that the retina of the eye can be damaged if the patient already had a retinopathy disease, or if he was very predisposed to getting retinopathy. Therefore, it is very important to ask about any history of retinopathy. And if so, then it is important to titrate semaglutide slower, which means that we give a low dose of semaglutide and we increase the dose much more slowly. So not in 4 weeks, but even longer. And it is important that you check the eyes with an ophthalmologist, and then you check it before the treatment and then 6 months after treatment. Retinopathy is very rare, so you don't need to be afraid of retinopathy, but it's important to check it out, okay? Now, the more common side effects now are very benign. This means that they are not dangerous like injection site reactions. They are nausea, for example, abdominal pain, we have diarrhea, reduced appetite, vomiting, constipation, flatulence, gastritis, gallbladder formation, acute pancreatitis, and so on. Then in the lab, we can sometimes see an increase of amylase or lipase, and these are the main side effects of semaglutide. I just rumbled them now. Let's make a quick summary of the most important things now about semaglutide. Semaglutide belongs to the family of GLP-1 agonists, which are usually injected subcutaneously once a week, and the trade name is called Ozempic. But semaglutide also has an oral tablet called Rybelsus, taking once daily 30 minutes before the breakfast. And then please always start with the smallest dose, which is 0.25 milligram of subcutaneous Ozempic, and then please increase the dose of the 4 weeks to 0.5 milligram. And if the blood glucose is still high, then further you can increase it to 1 milligram after 4 more weeks. The oral dose of Rybelsus is started with 3 milligram, and then it is increased after 4 weeks to 7 milligram, and further you increase it to 14 milligram if the blood glucose levels are still high. And before you start any medication, then please check the contraindications that we talked about. And after you give the medication, then always ask about side effects. And if you are interested in the other GLP-1 agonist or the other anti-diabetic medication, then please check my other videos about this. Remember the acronym that I talked about in the beginning, which is CELD, that stands for the members of the GLP-1 agonist family. S for semaglutide, E for exenatide, L for lixisenatide, L for liraglutide, and D for dulaglutide. And the last thing I just want to highlight, because I rumbled about the side effects a little bit too fast, I would say there are many side effects with all kind of medications, so not only with semaglutide. And it is so that I sometimes try to talk about this, that some companies have to simply just write a long list of side effects because they protect themselves by doing it. Because if the patient, if it's not there in this list and the patient somehow gets it, then he can sue this company and the company will get problems. So therefore they just simply write a long list of side effects. And therefore I would say sometimes it's ridiculously long, this list. Because in the practice you will not really see so many side effects as in this list. And the thing I feel is when patients ask me about side effects is always that, doctor, should I really take this medication with all this list of side effects? Yes, because the main side effects of GLP-1 agonists are usually nausea and abdominal pain, the most common ones. The rest are very rare. It's the thing is that the most dangerous one should be said and the most common ones should be said. And I have done that in this video. I said that the contraindications was medullary thyroid cancer and so on. This was the contraindication part. That is important to say. In the side effects part, I highlighted retinopathy. That is important to say because this is also dangerous. And I highlighted that before you start the medication, always check your eyes with an ophthalmologist. And he will check the eyes. If it's healthy, then you don't need to be afraid of this. It can happen, probably everything in life can happen, but the statistics say that if you're healthy, if you have healthy eyes, nothing will happen to you. Okay, I thank you very much for listening. Take care, bye-bye.